Okay, everybody. Thank you, everyone, for joining. It is now 12:03. We're going to get started with medical grand rounds for today, January 21st. We've got a really special and appropriate topic today, essentials in palliative care for COVID-19. My name is Chris Martin. I'm the Director of Medical Education, and very happy to have two of our local experts in palliative care joining us for this talk today. I'm going to introduce Dr. Jacky Lai and Dr. Michelle Van Walraven in a moment. Just in terms of the format for today, you'll see the slideshow on the screen. You'll hear Dr. Van Walraven and Dr. Lai's voices talk to the slides. Their presentation will take approximately 35 minutes, and then after that, lots of times for answering questions. Now, how we're going to do the questions is something called Slido. So if you want to open another window in your browser and just type in www.slido.com, you'll open up to a screen that says it's basically a question and answer platform. And at the top of the screen, you'll see joining as a participant and a number sign, and it says enter code here. And in that box, you're going to put 51238. So again, that's 51238 is the code for that. And at any point in the talk, you can type in a question. Then at the end, we'll address the questions and get our experts to answer that. I have a question already. I can't access the event by link. Says I need permission. So I will let our producer, Amy Dempster, sort that out. And that's from Dr. Crawford. So let Amy, gives me Amy's on it, Dr. Crawford, we'll get you on there. Okay, so that's for the questions. While everyone's getting that opened up, I'm going to introduce our two speakers for today. I'll first like to introduce Dr. Michelle Van Walraven. So Michelle grew up here in Simcoe County and we were happy to have her return to Barrie, where she graduated from the Family Medicine Teaching Unit in 2014. She practices community-based family medicine and palliative care at Royal Victoria Hospital, as well as in the community. She's an avid and excellent teacher and in family medicine, and works as a lecturer and as a supervisor at our family medicine teaching unit here in Barrie. And this is through the University of Toronto's Department of Family and Community Medicine. She's the education lead for palliative care for postgraduate education here in Barrie. Outside of that busy clinical and educational schedule, she likes spending time doing many activities outside with skiing, swimming with her two children, Gavin and Bennett, husband Neil, and dog, I'm going to say Quarry? Yeah. Got it. Okay. All right. So welcome, Michelle. And I'll introduce our second speaker, Dr. Jacky Lai. And Jacky's a family physician, again, practicing out of our family medicine teaching unit here at RVH. And he's also part of the Oncology Symptom Management Clinic. He did his medical training at McMaster and subsequently his family medicine resident here at RVH as well, homegrown as well. He's currently completing a Master's of Science in Community Health at the University of Toronto, although him and his wife are hopeful that finally they can say they're done going to school after this upcoming year. We'll see. You'll see your PhD, then you can say that, Jacky. Finally, immensely grateful for the mentorship and opportunities that he's received through the medical community in Barrie, particularly the staff at RVH and the FMTU. And we are very grateful for both you and Michelle, who are contributing massively to our hospitals, to our community, and to this hugely important area of palliative care, which I think is underrepresented and underappreciated across the board. And no more is it important in this current pandemic. And so your topic of palliative care in the COVID-19 pandemic is exceptionally topical. And again, looking forward to it. So without further ado, I'm going to hand it over to Dr. Van Walraven. You can get started.
Thanks, Chris. So thank you everyone for attending this session today. These are challenging times, but I'm happy that you're here or listening in as you want to learn more about palliative care, especially in the situation of COVID-19. We're all coming with different experiences in palliative care, and we hope that we can recognize that palliative care with patients with COVID-19 and their families has a distinct role and are quite significant because of the acute and uncertain nature of their illness. So Today, we have nothing to declare, or we're not affiliated with anything in particular, except our own memberships with different associations from across Canada. And as well, we're happy to have Jacky Lai as our palliative care clinical co-lead for the North Simcoe Muskoka Palliative Care Network. So again, as I said today, we hope to review with you the significance of palliative care medicine and end-of-life basics. We want you to be able to become familiar with advanced care planning and be more comfortable with having these goals of care discussion, especially for patients and their families with COVID-19. Be able to manage some of the symptoms of COVID-19 and be comfortable with some basic end-of-life care symptom management, and identify a palliative care approach. So when I talk about a palliative care approach, this is, again, it's palliative care is synonymous with hospice care or end-of-life care, but what we're talking about is an approach to their care for a patient facing a life-threatening illness or disease. And of course, those who are choosing comfort and a focus on comfort, we want to deliver palliative care to someone with COVID-19 in a very efficient and effective way. As you know, there are many sequelae that come from having COVID-19, of course, death being one of them, but many of these patients experience really prolonged restlessness and respiratory distress. And of course, we want to be able to ease their suffering and help both the patient and their family during this time. So the vision is to help patients live as they choose and to optimize their quality of life, allowing them to have comfort and dignity and security at the end of their life. We know, of course, there is a rapid decline sometimes in these cases, and we want families and patients to be aware. What I'm hoping to establish here at RVH and in our community is that most practitioners and most healthcare workers will be comfortable with basic level or primary level palliative care. So the way to look at it is the bottom of the triangle are all of our primary level palliative care people, and this can include specialists, this can include nurses, pharmacists, spiritual care. And I'd like to think of this team being able to execute basic level primary care for someone with COVID-19. As you go up in the model, you encounter more complex patients where the patient needs more specialized palliative care teams with more skills, and this is where we will get involved. We're going to start with some advanced care planning discussion and how to go about this.
Perfect, thanks, Michelle. So yeah, in establishing some primary level palliative care skills, one of the fundamental skills that we really want to work on is advanced care planning. I think it's a skill that all team members should consider practicing and becoming more comfortable with discussing a patient's advanced care plan. Especially in the context of COVID-19, we encourage the team to discuss a patient's goals of care at the initial assessment and admission to hospital. What we've learned is that patients with a suspected or diagnosed COVID-19 diagnosis may have a rapid decline in condition several days into their diagnosis, really resulting in a pretty bad respiratory distress or confusion if that happens. We know it's easier to have a conversation about goals when things are more calm than in a time of crisis. So for example, it may be helpful to start a conversation by asking, if things were to get worse, what would be important to you for your care? Next slide. There will also be times when patients are unable to express or make decisions for themselves. And when this happens, it's important to understand who would be making the decisions on the patient's behalf. The default in Canada is that the patient substitute decision maker makes these decisions, and it follows a hierarchy, as you can see here on the slide. That's that green region that we commonly default to as the SDM. The power of attorney for personal care is someone that the patient has chosen and is legally higher in the hierarchy than the default SDM. So oftentimes we also ask who someone's power of attorney of care is if they've already appointed someone. Next slide. Whether we're having a goals of care discussion with our patients or their family members, it's important to have a structured approach to the conversation because it can be tough and difficult for both ourselves as well as who we're talking to. I often find it helpful to ask for permission in initiating the conversation as it invites and prepares the patient. I also find it helpful to gauge patient and family understanding of their illness and the expectations by asking them, what has been shared with you about this illness and what is your understanding of what you could expect? Next slide. And in continuing the goals of care discussion, I really like this next technique that I'm going to share. It's called the wish, worry, wonder. It's a technique that's easy to learn, and I do encourage everyone to try practicing this, whether at home or with a colleague. An example is COVID-19 is a viral illness that we know can be particularly serious in patients like yourself. I wish we were not in this situation, and I'm worried that you could get much sicker very quickly. If this happened, you're at a high risk of dying from this illness. I wonder if we could talk about what you would want and what you would not want in your care if your condition worsens. I'll give some time for everyone to read some of these other tough questions that we have on the slide. These are things that we may ask patients. The answers may ultimately be helpful in finding out information that's important and meaningful to our patients. Saying these out loud and practicing them at home may be helpful. And I find that the more I speak about them and talk about them and ask these questions myself, I become more comfortable with asking these hard questions to patients. So we'll just stay on this slide for people to read.
Jacky, I also just want to point out that these questions give us more information than just asking a patient what their code status is or whether they want to be resuscitated. Patients don't appreciate those terms and what that means, but these types of questions are much more valuable in getting the right information that we need as a medical provider.
Absolutely. And then after asking those tough questions and having that conversation with patients, I like to close the conversation, and sometimes I find it helpful to summarize what the patient and family members have shared with us. I think it gives opportunity to recommend treatments and interventions that are truly based on what we know about this patient's values and goals. So for example, we can say, I've heard you say it's important for you that your breathing is comfortable and that we do not want to prolong any suffering. Keeping in mind what we know can occur with this illness, I recommend that we focus our energy and effort in treating your symptoms. If things worsen, I would not recommend us going into the ICU or be put on a ventilator, as that may prolong suffering.
So I just want to point out that we have developed a PPO for end-of-life care for an adult patient with suspected COVID-19. We also have a toolkit that's posted on SharePoint that you can access through SharePoint, clicking, sorry, I can't highlight where, but clicking on the SharePoint, then clicking on COVID-19 information, then accessing files and resources, and finally accessing the palliative care toolkit. I would encourage all practitioners who are caring for someone with COVID-19 at the end of life to utilize the PPO, as it does give a lot of good direction. As well, the toolkit has some of these resources, including a one-pager for symptom management for someone with COVID-19 at the end of life. So I would encourage you to access those resources. Here it is. Here's the one-pager that you can find easily online through Ontario Palliative Care Network or in the SharePoint. Some things to consider when caring for someone at the end of life. In most basic palliative care medicine, we start to discontinue medications that are not there for comfort. This would include antiplatelet agents, diuretics, statins, things that are, again, not there for comfort. Sometimes, for example, insulin for an insulin-dependent diabetic may be helpful to keep on, as we don't want them to get uncomfortable and going into early DKA. Focus on choosing a parenteral route because sometimes you lose the ability to swallow. So keeping those IVs for rapid access is important, but maybe consider discontinuing hydration because we know that hydration doesn't prolong or can sometimes worsen someone's symptoms, especially if they feel like they're drowning. Remember that COVID-19 symptoms do escalate quickly, and so be prepared to escalate these dosages. Sometimes, you know, again, checking in with nursing or you as a nurse knowing that you've given more than 3 PRN doses, maybe consider regularly scheduling these doses rather than just making it PRN. I'd like to also encourage you to not waste some of these medications. While we do have plenty supply, my understanding is as of now, we would not want to go into a situation where we are, of course, in a deficit. So it's important to stockpile some of these essential medications, which I know is done right now through pharmacy and is being done in the community. In many cases, when someone truly is at the end of life, we do stop monitoring vitals. Again, the focus is not on numbers. The focus is looking at the patient and assessing them for their comfort level. As you know, bundling care is important for limiting contact. Discontinuing different tubes, again, that are not essential for comfort, and considering discontinuing any other investigations. I do want to emphasize the second last point about the importance of providing spiritual care and comfort care and social work accessible here at RVH for someone and their family members who are passing away from COVID-19. I think we know that the grief and the bereavement part of COVID-19 hasn't been explored as much yet, but we know that it's quite significant. We know that most people at the end of their life want to talk about their spirituality, and we can alleviate a lot of suffering by just talking to them and having this connection. So if we have some virtual ways of doing this, I think it's really important that we are trying to do this for patients as they're very isolated for prolonged periods of time from their family. We're going to talk a bit about symptom management in particular. So first of all, airway secretions. We know that these patients have excessive airway secretions at times. Our usual first line of choice is using scopolamine, 0.4 to 0.6 milligrams, subcut or IV every 4 hours as needed. And this can sometimes be helpful because it does make them a little bit more sedated, and maybe that is part of their goal, is to just be comfortable and sedated. We have glycopyrrolate as a backup if you would want to use that. We also use some furosemide. It's been recommended to use them for someone who has a lot of lower airway fluids or secretions, and that can be given 20 milligrams subcut every 2 to 4 hours. Just remember they might need a Foley if you're going to be diuresing them. Finally, I see this a lot in positioning of patients who are having airway secretions. Someone who's conscious is usually sitting up, which is helpful, but for someone who's unconscious, it's actually more helpful to have their head down and their head turned to the side with their feet elevated above their head. This actually helps drain the fluid from their lungs and can make it a lot less noisy and more comfortable for the patient. But I want to remind you again that for someone who's unconscious, the secretions and the noises that you hear are not usually uncomfortable for the patient. It's more for us. And so again, just keep in mind you're treating symptoms. So if the patient looks comfortable, then you don't need to do much more than that.
Moving on to another common symptom that we are probably going to encounter, especially in patients dying of COVID-19, is dyspnea or breathlessness. Opiates are typically our primary first-line therapy for managing the symptom, even if the patient has underlying lung disease and we're concerned about thoughts about respiratory depression, which does occur. And although they can reduce respiratory drive when used in appropriate doses and monitored, they can be helpful in reducing the sensation of dyspnea and breathlessness, reduce anxiety, suppress cough, and really reduce the work of breathing. This allows patients to take calmer and deeper breaths as well. I generally like to start either morphine or hydromorphone subcutaneously or IV at these starting doses, which are quite low. And these could be up titrated as needed. It's always safest to start opiates at a low dose and titrate up when we need, and also keep into account if the patient was previously on opiates, then you may need to adjust those doses based off of their previous dose. If we're finding that we're needing quite a few PRN doses, like Michelle had, Dr. Van Walraven had previously mentioned, then it would be important to consider some routine scheduled dosing along with the PRN doses so that we don't get behind on the symptoms as these drugs wear off. Next slide. In some cases, we may encounter severe dyspnea, and these even high doses of opiates may not settle. In these situations, we might need to use something like midazolam to help relieve the discomfort. This could be given as either boluses to help sedate and manage the severe dyspnea or routinely, but ultimately midazolam can also wear off quite quickly. So there may need to be a consideration of continuous infusion. This specific technique of continuous infusion of a sedating agent is called continuous palliative sedation therapy. And if we're considering this, I would recommend consulting with a palliative care on-call service or our on-call service to help with this procedure. There are some details of this procedure that I think we can help support. It's important to be very clear with the expectations of this procedure as patients will be sedated. And using this procedure does require gathering consent from the patient or their substitute decision maker. Pain in the context of palliative care is also managed well with opiates. We follow the same principles of starting at a low dose and titrating up as needed. Switching between opiates can be done safely by looking at equivalency charts and conversion tables. It's not uncommon for patients to come in with something like Tylenol number 3s or oxycodones and need to be switched over to something like morphine and hydromorphone, which can be given either IV or sub-Q. One thing to always be mindful of is that the subcutaneous and IV doses are twice as strong as their PO counterparts or oral counterparts. For example, 1 milligram of hydromorphone subcutaneous is equivalent to the strength of 2 milligrams hydromorphone oral. So the written dose of subcutaneous doses is therefore half of the dose of what we would put down for the oral dose to get the same effect. Lastly, when using opiates, remember there can be unwanted side effects of constipation and nausea, as well as other rarer side effects. It may be helpful to have some bowel medications and antiemetics ordered preemptively.
So just some other symptom management points that might come up. Someone who's feeling nauseous or having some vomiting, our medications of choice to go to are haloperidol, 4.5 to 1 milligram subcut every 4 hours. We also use metoclopramide 5 to 10 PO or IV every 6 hours. Again, these are our choice because they can be given by a parenteral route. Fever management is usually done through acetaminophen, PO or PR. But again, I find at the end of life, when we're not measuring temperature, we're again just focusing on comfort. The symptom that I think has come up is cough in these patients. Opioids are helpful for managing cough as they suppress the cough reflux. Using hydrocodone can be helpful, and dextromethorphan 10 to 20 milligrams PO can be helpful for cough suppression.
Restlessness and
go ahead, Jacky.
Sorry. Restlessness and delirium may also be encountered with COVID-19 infections and really ending end of life, especially in the older populations. There are a few pharmacological options that we can use on top of our usual conservative strategies. So to try to orient the patient and try to limit the amount of noise and uncomfortable environmental stimulants. If we're quite restless, I tend to use and start with Haldol 0.5 to 1 milligram, subcutaneous or IV every 2 hours as needed as a starting dose, and this can certainly be up-titrated as needed. Combining this with lorazepam in the context of COVID-19 can sometimes be helpful, as anxiety and breathlessness can be a precipitant to restlessness and delirium. So lorazepams and benzodiazepines can help with that anxiety and breathlessness as well. If we're still continuing to find that the restlessness and agitation delirium continues and is hard to control despite higher doses, then we can consider the use of methyltryptamine, or commonly known as Nozanan. This can be quite effective in helping with symptoms of agitation, but before starting this, I do think it's prudent to make sure that the goals are quite clear with family members, as this is a really sedating medication and really generally used only in the setting of end-of-life care.
So finally, again, when to consult our team, or what can we do as palliative care specialists at RVH and in our community. Again, we're a very helpful resource for some of these symptoms if you're having trouble managing them. We do help with discussions around difficult goals of care or advanced care planning. We also help with coordinating home care. So for a patient who's in hospital and wants to go home, or a patient who wants to go to hospice, we're able to organize that. And of course, for some of those complex patients, we can be helpful to even just give a palliative lens. You know, consulting us is not a sign of failure that you're not doing the right thing, but can just offer a bit of a palliative approach to what's going on right now. Of course, we are available 24 hours a day at RVH for RVH inpatients. We are not in-house, but available by phone. So we're happy to take a phone call and talk with you over the phone to troubleshoot some of these difficult situations or point you in the right direction. As I pointed out, we are trying to make some of these resources accessible to you. If you want to learn more, there are webinars and modules available on some of these websites to better improve your skill set, or your toolkit, as we call it. I really just want to thank you for tuning in, and just remember to be compassionate to yourself and to others, and that grief is a process, and please take some time for yourself and be empathetic to others. So thank you for tuning in, and we do have lots of time for questions that we can answer now, or of course you can call us or email us later.
Wonderful. Thank you so much, Michelle and Jacky. I know that if everyone was in the room, there'd be tons of clapping right now. I'm sure everyone's clapping at home right now. That was awesome. We're just going to open up the question boards to Slido. So if people have questions, again, go on www.slido.com and type in your question, and I will pose it to our speakers. I've got one while we're waiting. It's a two-part question. The first one is how, I mean, I think that obviously COVID is disease is, you presented a great overview of the challenges with the cough and the breathlessness. How has it been, having the discussions with some of these patients, and more importantly with their families of patients who maybe not be able to consent when they're not able to actually visit? So you're doing these difficult conversations on the phone versus in person. That's the first part of my question. So I'll let one of you two tackle that.
Thanks, Chris.
I can.
Oh, go ahead.
Sorry, Dr. Sure, I can tackle that. So you're correct, Dr. Martin. It's certainly much more challenging now to have these difficult conversations with both patients and family members. And that's why we generally feel that it's been more effective to have these conversations early to set the stage rather than when the symptoms or condition escalates. Having these conversations on the phone aren't easy. A lot of the nonverbal communication and cues are what we use often as humans to see how people are feeling and responding to these questions. So it is a challenge. I think using some of the techniques that we shared today and practicing them and giving time and space, pauses in between these questions are ways that I found it to be helpful, both for patients and especially for family members to appreciate what we are saying. So I would say that despite the challenges of doing these over the phone, it's better to do them rather than not do them. So definitely something that we continue to work on and develop skill in doing, but the reality of where we are right now, it's something that we have to work with.
And so Jacky, would you recommend trying to do it on video because of those kind of physical cues, if possible? If you can take the time to set up a Teams call with the family member.
For sure, family meetings are very, very helpful, and if that could be done over video, you get to gauge the room, get to see who your partners are, who we're working with over this family meeting.
Yeah, and I found it even having the family be able to see the patient, because if they've been in hospital for a while, not been able to visit, they may look quite a bit different than what they remember them in their mind as, in terms of helping them make those decisions. Mm-hmm. Now, Michelle, question for you, or do you want to add anything to that question? Do you have a follow-up question?
I mean, again, I would just reemphasize what we discussed in the presentation. Really, the important tools are to set up the conversation, properly, as we just said, address their understanding of what's going on right now and share their prognosis and uncertainty, and explore these topics. So the same approach goes for any patient with a life-threatening illness. And as Jacky said, I think it's just important to practice that approach, and it becomes more comfortable whether doing it in person or on the phone, to be able to get those important conversations.
Awesome. And my next question is for, obviously the visiting restrictions have been a challenge for, around the times of patients, especially if they're being palliative and palliated. How do you tackle that? Because obviously it's different in the ICU in my world, where when people are palliated, it happens fairly quickly. But if it happens over days, how do we tackle the challenges of the visiting restrictions we have and the importance of having the family at the bedside during the patient's last days?
Go ahead, Jacky.
Sorry, Dr. Martin, can you repeat that once?
Oh, okay, sorry. No, sorry, I thought, Jacky, you had something to say. No, Chris, Chris, it is very challenging, you're right. And so, and especially as our restrictions get greater and greater during these times. So So again, I think to my understanding is we are making some exceptions, but in general, we have to use virtual visits with family members, especially, you know, these family members are likely infected with COVID-19 themselves, and they can't leave the house. And so we have to utilize the technology and the communication. And it's time consuming, you're right, to have to call and set these things up, but it's really important for the grief and the bereavement of the family who's going to be dealing with this afterwards to be able to have seen or talked to their loved one near the end of their life, if that's important to them.
Yeah, I think that's a great point, Michelle. And I know with one of ours, a patient unfortunately passed away in the ICU, we basically left the iPad running, and so the family could be present from all over Toronto, so they could be, you know, see their loved one during her last hours. Thanks. I got a question from an RVH legend, Dr. Dave Bushi here. What's the highest rate dose, I'm assuming, of dilaudid sub-Q you've used in COVID patients, especially with those with history of narcotic use?
Okay, so to be honest, I haven't encountered using dilaudid for pain very often in these patients, but and maybe Jackie, you can speak up as well after, but usually, Dave, when we get to a high dose of dilaudid, especially that requires more regular dosing, we go to a CAD pump, and that way the CAD pump can deliver the medication at routine intervals that we set and maintain a good baseline pain control, and it can be titrated up fairly quickly. In my experience with, say, non-COVID patients, some who have a history of opioid use or are not by all means opioid naive, sometimes I've had to go as high as 5 milligrams of dilaudid an hour, and that's by subcut. So again, it depends on that goal of care discussion with the patient and their family. And of course, I'd say if we're going up that high and using CAD pumps, that again is where our team is helpful for navigating you through what is acceptable and watching for opioid toxicity.
Thanks, Michelle. I'll add to that. I know it's not a competition, but I've gone up to 9 milligrams per hour of hydromorphone subcut before in a patient in the community. And this is someone that did have severe COPD because of a condition called alpha-1 antitrypsin deficiency. And they did quite well with their respiratory status and symptom control despite these high doses. One thing to be mindful of is if someone was opiate naive or they were really on just low doses of dilaudid to begin with, and they had really rapidly escalating symptoms, I know that we said we can up titrate the medications, but oftentimes one point that's hard is that if we are needing really, really rapid up titration, a lot of people don't do well with rapid up titration of opiates because they can get quite delirious and a phenomenon called neurotoxicity. So if we're finding that we're not really getting great control and we're trying to increase these doses of opiates to control their breathlessness, then it may be worth it to consider some other agents like benzodiazepines in combination to help with controlling these symptoms of breathlessness.
Great. Okay. Thanks very much. I just want to really quickly go back to our visitation. The IPAC team is a great resource for any questions around visiting around times of kind of compassionate reasons, especially if some of the family members, which is unusual, also have COVID or had recent COVID themselves. So don't be afraid to contact IPAC and the HSLs to help coordinate those visits. Another question here from on the board: how can we improve access to palliative care in times of COVID-19? And this may be in the community or in hospital.
So one of my points is really primary level palliative care can be delivered by anyone, right? Palliative basic or primary level palliative care can be delivered by family physicians throughout all of our community, and many of us do in Barrie and Simcoe area. accessing in RVH, of course, is through either a doctor-to-doctor consult to consult us at the palliative care team, or can be done through the North Simcoe Muskoka Palliative Care Network. So you can, we do have our palliative care network in the region with some very knowledgeable resource nurses who can offer support to both the physician and the family. And that can be put in as an order both at RVH or can be accessed from the community. We also have a fantastic community palliative care team that's led by Dr. Clark. They will offer palliative care in Simcoe region for home-based patients. And of course, our Hospice Simcoe is another great resource for accessing any information. I think really the point is just to recognize when you are crossing over to a palliative care approach and keeping that lens on, the lens that you are offering comfort. You are not curing someone. You are goal is to alleviate the suffering. And again, that can be done not just through physicians, but through many other practitioners and members of their care team.
Okay, thanks, Michelle. Another question here for either your view is, what can we do to help educate the public on the specific challenges that all of us, patients, families, and clinicians are facing? And I'm assuming they mean kind of palliative care in the context of COVID. So how can we educate the public on that?
Okay, so I think it starts, it starts with all of us. It starts with the hospital promoting the importance of having these discussions with your family. It starts with your family doctor initiating some of these conversations with your family. There are some really good resources out there. Speak Up Ontario will offer booklets to sit down with the family that they can do themselves to have these discussions. Pallium Canada and also BC, Pallium in BC have lots of videos that are based and geared towards patients in order to promote having these discussions beforehand. I think as you're hearing, the most important thing is to be prepared, right? And I know our long-term care homes are having these discussions or I know physicians in the long-term care homes are having these discussions with all of their patients, but we in the community should be addressing this with our frail patients or with our at-risk patients, which there are a lot of them. I think it starts with, again, normalizing it in this context, that it's important to have these types of discussions now, so everybody knows what to do.
All right, great. Really interesting question here, which I think we'll have a bunch of answers for. Have you had any personal experience in palliative sedation in COVID patients? And do people choose ventilation due to exhaustion?
I have not, Jackie, or maybe Chris, you might be better at answering some of this too.
Yeah, I was going to say Dr. Martin probably has the most experience.
I don't know about that. So I think that I'm gonna tackle we've done palliative sedation on many COVID patients, and I think that the ventilation question is a great question, and this is in palliative care all the time. It's if someone's being palliative, how much oxygen do you give them? Like, do you, and that's a question that we ask all the time. Like, do you limit the oxygen? If they're breathless until you get their symptoms under control, do you titrate up the oxygen? And we get asked all the time, oh, can you bring this person down to the ICU because they'd be less breathless if you put them on BiPAP, or if you put them on a ventilator? And that potentially is true. However, when we talk about offering ventilation or non-invasive ventilation like BiPAP or CPAP, we have to offer a treatment that's going to offer them benefit. And so as part of their care plan, before we'd even discuss that, we would have a discussion, okay, would non-invasive ventilation or invasive ventilation aid you in recovering to a quality of life that you would find acceptable? And if the answer is no, then that's not offered as part of their care plan. And so we wouldn't put someone on non-invasive or invasive ventilation because it would make them, quote unquote, more comfortable. I think we would get an early palliative care consult from our colleagues and make sure they're on the right medication. And with the right medication, the right dosing, with the right people doing it, you shouldn't have anyone to a point where they're like, oh, give me that BiPAP because I'm really struggling here. And so that would be the answer to that question. And I think that again, with just using some of the techniques that Dr. Lai and Dr. Van Walraven have described, we've I think successfully made sure that when unfortunately our palliative care or our COVID patients who whose care plan did not include ventilation, they did not want a non-invasive ventilation or invasive ventilation. With the techniques that they've just described to you, we provide a very good palliative care, and these patients are very comfortable. We don't accelerate the process. We just make sure they're very comfortable throughout there. And we've done all the other important things to try to make it as peaceful and as dignified for them as possible. Anything you guys want to add to that?
No, thank you, Chris. And I think we are going to be having these conversations more often now. And I do think there can be a team approach to this if you ever need one of us to be part of that team to have these types of conversations with patients.
Okay, thanks so much, Michelle. Another question here. Is there any resources we could share with patient families after a patient passed away to assist with griefs and next steps? Matt Moss. And that's a really good question, because I find that sometimes we do lack a piece that sometimes, and I know that's a hole sometimes with some care that we like, patient passed away, they're like, what do we do now? And then the nurses are excellent at it, but we as physicians, I think at least the non-palliative care physicians are often a little bit like, okay, I think there's a package for you. What do you guys recommend?
I could take this one. So there's lots of resources, fortunately, for our patients and their family members, even before they pass away. So lots and lots of resources that we have provincially, lots of resources that we have also locally. I know that Dr. Van Walraven spoke about consulting spiritual care and social work. So these are for patients that are in hospital already. They really can benefit from an early referral to social workers and spiritual care. But for, say, Dr. Moss in the emergency department, if you do want to refer someone to a local resource, our local hospice SYMPTOM, has a community team that helps with grief counseling as well as grief groups. That's a great resource. They're well staffed, they're very trained and very experienced, and they would love to touch people in our community to help them through a difficult process. Family members can also go on a website that's Canadian nationally run called mygrief.ca. It's run by an organization called Canadian Virtual Hospice, and they have lots of modules, videos, information. So we could certainly put that on the slide too, but it's spelled mygrief.ca.
Thanks very much. Sorry, go ahead, Michelle, you want to add something?
And in Barrie, we also have the Season Center for Grieving, and this is for children, particularly under the age of 18, who have lost a loved one, and that can be accessed for all children as well. So that's the Seasons Grieving Center.
Those are, yeah, maybe we'll post those up when we post the video. Those are good resources. I would like to give a shout out to our social workers and our spiritual care at the hospital. They are amazing. And so as Jackie and Michelle said, do not hesitate to call them. They are wonderful resources, so comforting for the families in all these situations. So please reach out to them because they're incredible. Okay, next question. Palliative care teams, how can they be best utilized in the emerge department? Should someone be embedded physically or via telehealth, given that many of these patients come through the care of the emerge in all parts of their journey?
That's a very interesting question, and I mean, traditionally we've been available by phone, as I said, 24 hours a day to offer some support or suggestions. You know, we occasionally, when we're on call, we do go into the emerge if necessary. As for embedding someone permanently, that's an interesting concept that actually has come up from the GTA hospitals. You know, are we at the point where we should actually have a dedicated palliative team in our emergency room? And I think we're willing to open that up for discussion. times are changing and we need to change fast too. So I think that's another good resource that we could try to work in.
And I guess to that follow up on that. So if someone's in the emerge who I think may benefit from palliative care, how was it including your slide of how's the best to refer them into the community to the palliative care team if they're not already involved? Let's say I find the oncology patients are often linked in, but some of the non-oncological diagnosis, cirrhosis, COPD, congestive heart failure, sometimes don't have those links. How's the best way to set that up as an outpatient?
So there's two resources I'll talk about. One of them is the North Simcoe Muskoka Palliative Care Network. So there is a referral page, usually I think it's online on their website. It's accessible on many floors at the hospital. So the North Simcoe Muskoka Palliative Care Network has two purposes. One is for educating families, and the second is for finding a palliative care physician in the community to care for a patient. So if you encounter a patient in the emerge or even on service that is going home and you think, we need to have more discussions around this with the family, or more maybe specialized care that maybe is not being provided by their physician right now, you can always just submit a referral. It's a one-page referral to the Palliative Care Network, and check off what you're looking for. The second resource is Hospice Simcoe again. So Hospice Simcoe has an outpatient palliative care clinic. So again, this is run by some of our fabulous community-based palliative care physicians who do care for people in Simcoe County, and you can refer them to the Hospice Simcoe clinic. And this is for any diagnosis. Again, a lot of the time, the oncology patients have great access through the cancer center, but for non-oncological patients, this is another great resource to access a palliative care physician, either just for a consult or to take over their care. So again, in the emerge, you can send those two referrals off to the Palliative Care Network and to Hospice Simcoe, or call us and we can direct you how to do that or where to find that information, and go from there.
One thing I wanted to note for that is, in follow-up, Dr. Martin, if you have a patient that you're discharging from the emerge, but you truly think that they're frail, their disease is at an end-stage condition, a lot of our patients have excellent family physicians in our community, and a lot of our family doctors are very skilled in providing those goals of care discussions, that primary level palliative care, and supporting them either in their clinic or even during home visits. We're fortunate enough in our community that we have really family doctors that have been trained to provide comprehensive family medicine. And sometimes they just need the permission to say, hey, look, the emerge was really concerned about you. I now have permission to follow up. So I would encourage emerge docs, if you feel like the patient needs that follow-up from a palliative lens, perhaps maybe sending a quick note, giving a quick call or a message to the family doctor's office and saying, patient was quite sick, would benefit from a palliative approach to care. That initiates that process for us, and that's often very helpful.
Wonderful. Thanks so much, Jacky and Michelle. So I don't have any other questions on the board here. So, and it's 12:56, so perfect time. Everyone likes to be done a little early. I'd like to thank both of you. That was a wonderful, informative presentation. And I'm sure the viewers that were watching learned a ton. I learned a ton. And I want to thank you guys for your expertise, your compassion. We're very lucky to have you in the hospital and in our community. And I'm looking forward to seeing how you'll take our palliative care even further in the future. So for those people who didn't get to watch it today, it will be shared, and then we're going to send out a link for people who want to watch it later. So if your colleagues didn't have a chance to log in, Jessica Calderon from the Medical Affairs will send out a link later. But again, I'd like to thank Jacky, Michelle, Amy Dempster, and Jessica for setting this up. Great talk, and thanks again, everyone.